Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a case discussion and it's going to be about carcinoma of maxilla. Now this is a very important case that we get as residents in our clinics and OPDs, and very commonly this will come as your long case, and there's so much to know over here, so many lines of viva questions that can be asked. We'll be discussing each one of them today. So we'll start off with the history and we'll discuss some questions related to the history. Then we'll move on to discussing what are the findings in the patient and what kind of questions that can be asked. And finally, we'll summarize the case. We'll come to a provisional diagnosis and we'll discuss also the management and some points related to carcinoma of maxilla. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with our case. So we have a 55-year-old male here who lives in Bangalore, Hindu by religion, carpenter by occupation, came with the chief complaints of bilateral nasal obstruction for 2 months, nasal discharge from left side for 1.5 months, and swelling in the left cheek for 1 month. Coming to history of present illness, patient is apparently asymptomatic 2 months back when he started complaining of bilateral nasal obstruction, which was insidious in onset, initially involving only the left side, rapidly progressive to involve the right side as well within the next 20 days. Obstruction is complete on the left side and partial on the right side. It's continuous throughout the day and there is no aggravating or relieving factors. Next complaint, he's also complaining of left-sided nasal discharge since the last 1.5 months, which is insidious in onset, mucoid in type, blood-stained occasionally, which is spontaneous, non-foul smelling, continuous in nature, and there is no aggravating or relieving factors. He is also complaining of a swelling in the left cheek since the last 1 month, which has been insidious in onset and gradually progressive to attain the current size, and there are no aggravating or relieving factors. This is associated with numbness of the left cheek. There is also a history of mouth breathing and snoring and a history of hyponasal speech. Now coming to some negative history. Again, see, negative history itself is not a particular heading that you write under. I'm just giving it here so that you understand that there's so many other history that you would have to keep in mind when you come across a case like this. So these are the histories or the complaints that you will inquire around. There is no history of frank nasal bleeding, sneezing, postnasal drip, headache, double vision, protrusion of eye, decreased vision, watering of eye, difficulty in mouth opening, loosening of tooth, discharge from alveolus, tooth extraction, ill-fitting dentures, swelling in palate, ulceration in palate, swelling in neck, nasal regurgitation, difficulty or pain in swallowing, change in voice, fever, cough, significant weight loss, appetite loss, nausea, vomiting, personality changes, any ear complaints, or any radiation exposure. So these are all the negative histories also that we have taken into account. Coming into past history, there is no history of similar complaints in the past, no history of diabetes, hypertension, bronchial asthma, TB, epilepsy, thyroid disorders, etc. No history of surgeries in the past, no history of drug allergy, blood transfusion, no significant family history, sleep is reduced, appetite is normal, diet is non-vegetarian, bladder and bowel movements are normal, and there is an addiction history of bidi smoking, which is 10 per day for the last 35 years. So that is our history so far. Now we are going to start discussing some questions related to the history portion. So now, first of all, we have an elderly male over here, right? So our patient here is 55-year-old. So what is the importance of age, especially in a case like this presenting to you with a nasal obstruction, especially a nose case, for example? What are the things that will pop into your mind based on the age group? So if it was a young patient, we could consider juvenile nasopharyngeal angiofibroma, which we know very commonly that we see this in pubertal males, adolescents, right? And AC polyp, we'll see AC polyp cases in young children. Then the middle-aged group, they are seen to more commonly have rhinosporidiosis, bilateral ethmoidal polyp, inverted papilloma, An inverted papilloma you'll see commonly in the 5th to 6th decade of life. Then coming to our age group over here, which is 55. So we can see that the elderlies, they have a more tendency to have sinonasal malignancy. It's very common in the 6th to 7th decade of life. Then another very important question here, there are two cases of nasal mass or in which we see a bimodal age distribution. First is we have olfactory neuroblastoma, where we see a peak at two different age groups. One is around the age of 20 years and second is around the age of 50 years. Whereas in nasopharyngeal carcinoma as well, this is a very important MCQ question. You can very easily be asked about bimodal age distribution. Nasopharyngeal carcinoma sees a first peak in 10 to 20 years age group and a second peak around 40 to 60 years age group. So it's important for you to know which disease is more prevalent in which age group. This gives you a fair idea related to the nose cases. Next point. What is the importance of gender? So you'll see certain diseases will be more common in males and certain diseases will be more common in females. So there are two specific diseases you'll see that will be more common in females. A higher incidence is seen in females. So these are olfactory neuroblastoma and malignant melanoma. Again, this is a very important MCQ question. You may be asked, like, out of all the sinonasal malignancies, what are some of the pathological types that are more commonly seen in females? Because most of the other ones, you'll see the incidence in males is way higher. So this is a very important question. Other than this, other cases like JNA, for example, we know that it occurs more commonly in males. Even inverted papilloma has higher incidence in males and sinonasal malignancies mostly as well. And the most common sinonasal malignancy that we have is a squamous cell carcinoma. And squamous cell carcinoma, we see that male predominance over female. The only two sinonasal malignancy where we see a female predominance are olfactory neuroblastoma and malignant melanoma. So this is something we gotta keep in mind. Next, we come to the importance of occupation. So we found our case that the patient is a carpenter, right? So why did we take the history of the occupation? That actually gives you an occupational exposure history, that the person get exposed to some kind of carcinogen or any other factors. So the importance of knowing the occupation is to know exposure and also to know what this exposure can cause, what kind of disease it can cause. For example, sinonasal malignancies, we commonly see it in people who are exposed to the nickel and chromium industry or has been exposed to wood dust exposure, especially in the furniture industry, and radium dial painters. This wood dust exposure, this is a very important question. This is one of the most important etiological factors seen in sinonasal malignancies. And here, the type of wood dust that the patient has been exposed to kind of determines the pathological type of carcinoma that will happen. And very commonly asked question here is, hardwood exposure predisposes the patient to develop adenocarcinoma and softwood exposure will predispose the patient to develop squamous cell carcinoma. So that's about sinonasal malignancy exposure. Other than this, there are other diseases as well. For example, you'll see in farmers, rhinosporidiosis is more common. There can be a history of pond water bath. That's something you should be asking in these patients as well. If they have come to you with a case of unilateral nasal mass, in that case, history of pond water bath, farmer, all of these history will point you towards rhinosporidiosis. Exposure to very dusty environment can predispose the patient to vasomotor rhinitis. And a pollen exposure can increase the chances of allergic rhinitis and nasal polyp cases, especially ethmoidal polyp cases. So these are all the important things that you need to know when it comes to occupation. So every point that you're noting down when you're meeting your patient and you're asking them where do they stay, what kind of work do they do, what is their age, all of those factors are leading up to something. They are giving you some kind of a clue as to what the disease is. So it's very important that you know that. Now next, coming on to the chief complaint. So our first chief complaint that we saw was a case of bilateral nasal obstruction, which was there for 2 months. So since we already know that we are discussing a case of CA Maxilla, I would like to ask you, usually this starts as a case of unilateral nasal mass, right? So, how does a case sinonasal mass which has started on one side, why is the patient here complaining of bilateral nasal obstruction? Can you tell me the reasons why a patient of a CA maxilla case can complain of bilateral nasal obstruction? So, we have 3 reasons over here. Number 1 reason is that the tumor has filled up the whole of the ipsilateral nasal cavity that it has originated from. Now, it has pushed the septum to the other side. So if this is our nose and this is our septum over here and a mass is developing here. So when the mass has now grown like this, what it will do is, it will push the septum across the midline towards the opposite side. So you can see how you'll end up developing bilateral nasal obstruction because the unilateral nasal mass has pushed and deviated the septum. So that is our first cause. Second, it can also happen that the nasal mass has destroyed. There is a destruction of the nasal septum and bulging into the opposite side. So if this nasal septum gets destroyed and there's a septal perforation developing over here, the mass can actually invade the septum and end up going to the opposite side of the nasal cavity. So that is the second reason. Third reason is when a sinonasal mass is growing, it also grows posteriorly, right, towards the choana. So now when this mass has reached the choana, the next region it is reaching is the nasopharynx. So now when it reaches the nasopharynx, it will keep on growing more. It can block the other side choana as well. So when the other side choana is getting blocked and the nasopharynx is getting blocked, your posterior airway is getting blocked. So that will also cause a case of bilateral nasal obstruction. So these are the 3 reasons why you would see a case of bilateral nasal obstruction in a case of CA maxilla. One is it has pushed the septum across the midline. It has caused a destruction of nasal septum and bulged into the opposite side. And third is it is going posteriorly into the choana, into the nasopharynx and obstructing the posterior airways. Okay, next question. We saw that our case was a case of bilateral nasal obstruction, and initially he only had involvement of the left side, but it rapidly progressed to involve the right side as well, and the duration is very short. So within 20 days of time, both side of nasal cavity got involved and both side got obstructed. So what is this pointing towards? So rapidly progressive is a very important term because this will be pointing you towards some kind of a malignant growth. Whenever you take the history, if the patient has said, oh, it's taken a couple of months, maybe it's taken 4-5 months before the other side got involved, that is a case of gradual progression. Gradual progression is always pointing towards more of a benign condition, like for example, some kind of a benign polyp or a tumor, etc. So that history is also very important. This rapidly progressive is telling you that the disease is growing very fast and it is most likely a malignant disease. So that's our next thing. Next, we move on to discussing nasal discharge. So this patient has complained to you that they are having left-sided nasal discharge since the last 1.5 months, which is insidious in onset. And when we heard the character of the nasal discharge, we heard that it is mucoid in type, occasionally bloodstained, which is spontaneous, and it is non-foul smelling. So, mucoid in type, maybe it can point you towards that maybe the sinus is getting obstructed. Maybe if the sinus ostia, if there's a nasal mass growing inside, the sinus ostia can get obstructed and that can lead to the development of sinusitis and that will lead to a mucoid nasal discharge. But they have also said that it's occasionally bloodstained. So if for example, this was a case of polyp, it should not have a bloodstained nasal discharge. So that brings us to the question, what are some causes of bloodstained nasal discharge that you'll have in mind the moment you get this history. So it's not just a malignant tumor, right? It can be many other things. So causes of bloodstained nasal discharge, it could be a case of GNA, a neglected foreign body, rhinolith, rhinosporidiosis, inverted papilloma, malignancies, atrophic rhinitis, trauma, vaginous granulomatosis, and multiple other such causes, or all these granulomatous diseases. These are some examples to keep in mind. So immediately when you have heard of bloodstained nasal discharge, these are the DDs that will come to your mind. So we can see that malignancy is part of that. We can also see a benign tumor like inverted papilloma is also there. Rhinosporidiosis is also there. So common question here that I would like to ask you is, say you have gotten a case of unilateral, foul smelling and blood-stained nasal discharge. A case of this. Now, let's apply it to two cases. One is a child has presented to you with this, and the second is an adult or an elderly patient, rather an elderly patient has presented to you with this complaint. What is it that you will be suspecting? In case of a child, number one, you will be thinking when it's a case of unilateral foul-smelling, blood-stained, even sometimes purulent nasal discharge, you will be thinking maybe it is a case of foreign body of the nose. Because very commonly children will be playing with some toys and they'll push something up their nose and maybe they didn't tell anybody about it and it's been stuck there, it's neglected. Eventually, it will end up causing a foul smell, blood-stained discharge occurring. So in a case of child, you will be suspecting foreign body. Whereas in a case of elderly adult, in that case, you will be thinking of a sinonasal malignancy. This is a very, very important question that you can be very commonly asked in your viva questions. So this is something to look forward to. Next, so we have discussed about the left-sided nasal discharge. We also found that it is non-foul smelling. So that also rules out a lot of conditions like, for example, the bloodstained, for example, foreign body, etc. And there's no other features as such here. Moving on to our next chief complaint, which is swelling in the left cheek. So our patient is complaining of swelling in the left cheek since the last 1 month. So this will make you think, okay, patient has come to me with a case of nasal obstruction. They have also nasal discharge, which is bloodstained, and they have a swelling of the cheek. So what are the differential diagnoses that comes to your mind when you think of swelling in the left cheek? So let's think of structure-wise. So if you look at the cheek, what are the structures over here that can lead to the development of a swelling? We have skin on top, then we have subcutaneous tissue, then further down we have bone, and then we have our maxillary sinus, right? So when you go further in, we have the maxillary sinus. So there can be causes related to each of these layers. So if the skin was involved, maybe it could be a furuncle, folliculitis, basal cell carcinoma, or an infected acne. Subcutaneous causes could be fibroma, lipoma, neurofibroma of the infraorbital nerve. We know that the anterior wall of the maxillary sinus transmits the infraorbital nerve via the infraorbital foramen. So a neurofibroma involving this nerve could also cause this. So that's one of the causes. Then we have hemangioma, lymphangioma, lymph node swelling, sebaceous cyst, subcutaneous phycomycosis. So these are the subcutaneous causes that could possibly cause. Then we have some bony causes like fibrous dysplasia, osteoma, adamantinoma, dental cyst, dentigerous cyst, aneurysmal bone cyst, osteosarcoma, osteoclastoma. These are all some bony causes that can also lead to the development of a cheek swelling. Then we have sinus involvement, like if there is a malignancy involving the maxillary sinus, we know that the anterolateral wall of the maxilla is related to the cheek. So if this wall has been invaded, it will lead to the development of a cheek swelling. Then various granulomatous conditions of the nose also can lead to this. So these are some differential diagnoses that you can keep in mind when it comes to cheek swelling. Next, moving on, the patient has also said that it is associated with numbness of the cheek. Now, what does this indicate? So I just mentioned the anterior wall, it transmits the infraorbital nerve. Now, infraorbital nerve is actually a branch of the maxillary division of the trigeminal nerve, right? So we know that we have a trigeminal nerve supply happening over here. So this nerve, if this wall is getting infiltrated with a swelling, this nerve is very prone to invasion. And when infraorbital nerve gets involved, this basically supplies the region in the cheek. So if infraorbital nerve has been involved, the cheek sensations will get involved, and that will lead to numbness of the cheek. So a very simple history over here is pointing you towards what structure has been invaded in your case. So numbness of cheek is most likely indicating that the infraorbital nerve has been involved, meaning the maxillary division of the trigeminal nerve has been involved. Next, we have a history of mouth breathing and snoring. Now, what does this indicate? So, whenever the patient is complaining of mouth breathing and snoring, it basically means that there is some kind of obstruction that the patient is facing in their airway, right? So it could be possible that the mass has grown posteriorly. We already know that the patient is complaining of bilateral nasal obstruction. One side is complete, one side is partial. So we know that there is some kind of a mass growing inside that is causing this obstruction probably. Then we have hyponasal speech history as well. What is hyponasal speech? Hyponasal speech is basically when there is a reduced or an absent nasal resonance during speech. This has a very common name that we know it by. Can you tell me that? So this is known as Rhinolalia clausa. So we have two conditions, Rhinolalia clausa and Rhinolalia aperta. We'll talk about it just after this. So this is a case of Rhinolalia clausa. And what does Rhinolalia clausa indicate? This indicates when there's an absent or reduced nasal resonance, this is indicating that there is probably some kind of obstruction either in the nose or in the nasopharynx, and the airflow is unable to reach or resonate in the nasal cavity during the time of speech. So this is our important history over here to know that this is some kind of obstruction happening here. So that's about our hyponasal speech. And before we move on, let's discuss what is Rhinolalia clausa and what is Rhinolalia aperta. What is the differences between them? So, if we look at the character of the speech, we just mentioned Rhinolalia clausa is hyponasality of the speech, whereas Rhinolalia aperta is hypernasality of the speech. Clausa is happening, the mechanism behind is that there is an obstruction to the nasal airflow, whereas aperta is happening because of the escape of air into the nose during the oral sounds. Now, what is the cause behind each one of them? As I mentioned for clausa, the cause would be a blockage in the nose or the nasopharynx. So, an obstruction in the nose or nasopharynx is what will lead to hyponasality. Whereas, velopharyngeal insufficiency or some kind of palatal defect which is causing an escape of air, there is no patency here, there is an escape of air occurring into the nose during the time that you're trying to produce an oral sounds. That is the main cause behind Rhinolalia aperta. So what will the sound, the type of sound that you're trying to make, what will it sound like? So in case of Rhinolalia clausa, the nasal consonants like M, N, and G, these things will sound like B, D, G. The nasal tonation, the resonance will be lacking. Whereas in case of aperta, the oral sounds will get a very nasal twang. And some common causes for Rhinolalia clausa, you can imagine any cause that will obstruct the nose and nasopharynx like TNS, polyp, adenoid hypertrophy, sinonasal mass or nasopharyngeal mass. And for Rhinolalia aperta, think of any cause that is causing a velopharyngeal insufficiency or kind of a palatal defect. So there can be a cleft palate, palatal fistula, submucous cleft, palatal palsy, etc. So that's about the differences between the two. I can give you a small trick to remember. Sometimes we get confused which one was Rhinolalia clausa, which one was hyponasality, which one was hypernasality. It can get confusing. Just remember one small thing. Rhinolalia aperta has P in the spelling. P is for palatal. defect. So if you can remember that Rhinolalia aperta is occurring from a palatal defect, you can remember the other one is obviously occurring from defect in the nose or the nasopharynx. So that's about the differences between Rhinolalia clausa and Rhinolalia aperta. Next, moving on, we have discussed already our 3 chief complaints and some questions related to it. Now we are going to move on to discussing all the negative history. So now why were we asking all of these histories over here? Let's discuss each one of them one by one. So if there was a history of frank nasal bleeding, that would have pointed towards a more vascular mass. More vascular masses like angiofibroma, or hemangioma or hemangiopericytoma. And this kind of frank nasal bleeding is usually suggestive that the nasal mass is extremely friable. So that would have given you some clue. A history of sneezing and post-nasal drip, we'll see this history more commonly in a case of allergic or inflammatory mass like a polyp. For example, if a nasal polyp came to you with a history of allergy, you would know that, okay, this is probably a case of nasal polyp. And here, usually an obstructed sinus drainage leads to a secondary infection. And sometimes even this history can suggest a posterior growth of the mass. Maybe while the growth was growing posteriorly, it has obstructed the sinuses and it has led to a secondary infection of the sinus causing sinusitis, because of which you are having post-nasal drip. So that's something to know. Then, if this patient was complaining of headache, now think of a case of sinonasal malignancy complaining of headache, one of the things you will be thinking about is there an intracranial spread over here? That's something to think about. Or it can even be that the sinus has gotten obstructed and it has caused a raised pressure leading to headache. Then we have double vision. So double vision, so you'll see that sinonasal malignancy can have a lot of orbital involvement. So if there is orbital involvement where the extraocular muscles have gotten involved, or even the cavernous sinus thrombosis has occurred. Cavernous sinus thrombosis, you'll see a lot of nerves getting involved, for example, the 3rd, 4th and 6th nerve, for example. If these nerves get involved or any extraocular muscle has been invaded, it will cause double vision or diplopia. If you see protrusion of the eye, that will suggest that the tumor has extended to the orbit, and the direction of the protrusion of the eye will help you in understanding where has the tumor originated from, which sinus is the primary sinus involved over here. Next, decreased vision. Now, decreased vision is actually quite a red flag sign. It can indicate that probably the optic nerve is getting compressed or invaded, or there is an orbital apex involvement. These are very red flag signs to look forward to. Then, if the patient has complained of watering of eye, we know one of the structures that opens into the inferior meatus, we have the nasolacrimal duct. If the nasolacrimal duct of the lacrimal passage, it got obstructed because of the mass, that will lead to watering of the eye. So this will indicate the obstruction of nasolacrimal duct. Next, we have difficulty in opening mouth. Now, we'll talk about tumor spread also today. What are the different directions in which a case of carcinoma maxilla spreads, and what are the structures it will involve in each direction. Now, we'll talk in details later, but just for now, I'll tell you, if our tumor was spreading posteriorly. Now, if you imagine the anatomy of the maxillary sinus, you'll remember that posteriorly lies the infratemporal fossa. So if the tumor was growing posteriorly beyond the maxillary sinus and has reached the infratemporal fossa, the two muscles that it will infiltrate is the medial and the lateral pterygoid muscle. And these two muscles, we know how important they are. They are the muscles of mastication. They are responsible for moving the jaw. So if these muscles get involved, there will be the development of trismus. And the patient will have difficulty in opening the mouth. And as soon as you find this will immediately upstage your tumor to T4 category, because this will indicate that the tumor has reached the infratemporal fossa. Again, we'll discuss about the staging classifications of maxilla also later in this class. But so just a simple history of difficulty in opening mouth will tell you how advanced the disease is in this case. Then loosening of tooth, discharge from alveolus, tooth extraction, ill-fitting dentures, all of these things involving the tooth. This will tell you whether there is an inferior spread of the tumor happening. Now, if you remember the floor of the antrum, we have the alveolus attached over there. We also have the hard palate. So if we are having these kind of symptoms, loosening of tooth will indicate that there has been an alveolar bone or socket invasion. Discharge from the alveolus will indicate that there is probably a secondary infection of the eroded socket occurring. This will be a sign of bone destruction. If the patient gives you a history of tooth extraction, that will suggest probably there is a non-healing socket. Maybe there's an underlying malignancy. Ill-fitting dentures. This is also a very important question to ask your patients. Ill-fitting dentures history will suggest that there is probably an alveolar ridge resorption or distortion, because of which the dentures are not fitting properly anymore, which used to fit earlier. This is often a very early sign and which you can very easily miss that there is some kind of maxillary pathology happening over here. Then we have swelling in the palate or ulceration in the palate. So as I told you, the hard palate lies inferiorly. So if there is an inferior spread of the tumor happening from the maxilla, it will involve the palate, and that will cause either a swelling or even an ulceration. You can even find an oroantral fistula. So that's why you should take the history of these things as well. Next, if the patient had complained of some kind of smell abnormalities, it may indicate that the olfactory mucosa or the cribriform plate has been involved. This will suggest that there is a superior extension of the mass. Then swelling in the neck. This will suggest that maybe there is a cervical lymph node metastasis. So we'll talk about the regional spread of tumor later on. So even a maxillary sinus can have nodal malignancy, nodal spread. And if that does happen, we will see a nodal swelling in the neck. And this will be a sign of regional spread. And again, if this is present, this will affect the staging of your tumor. Immediately, it will end up upstaging your tumor, and your tumor will become more in the advanced category, and hence your treatment protocol to your patient itself will change. So swelling in the neck will directly change the treatment of your patient. Next, we have nasal regurgitation. Now, if there was nasal regurgitation happening, we can suspect maybe there is some kind of palatal involvement, soft palate, there's a palatal fistula, maybe there's a palatal perforation. If there is a complaint of difficulty or pain in swallowing in this particular case, that can also indicate that there is a oropharyngeal or a soft palate extension or an advanced local disease. If there is a history of fever and cough. Now, this is very important. Our patient can have a distant metastasis as well. We'll learn about what are the common sites, but one of the common sites that can be involved is the lung. So if the lung is involved, the patient may have a history of fever, can have a history of cough. So these will help you in directing towards that, or it can even direct you towards an alternate diagnosis. For example, tuberculosis. Tuberculosis, you'll typically have an evening rise of temperature and a cough history, or other granulomatous diseases as well. So these are all pointers that will help you in ruling out a lot of things. Then significant weight loss or loss of appetite. These kind of history are constitutional symptoms that you see in malignancy. And lastly, we have some more like bone pain. So bone involvement is another one of the distant metastasis sites that can happen over here. So if there is some kind of bone pain, we will suspect distant metastasis. Then we have nausea, vomiting. That will suggest an intracranial extension of the mass. If there is some personality changes that you're seeing, that will typically indicate that probably the frontal lobe of the patient has been involved. And if the frontal lobe of the patient has been involved, what will we suspect? We'll suspect that there is intracranial involvement. Probably there has been a anterior skull base breach. So your treatment strategy and everything will change over here. Then, what is the importance of taking ear complaints in this case? So as I told you, when the sinonasal mass is growing, it's growing posteriorly as well. It's reaching the choana. Now it has grown beyond the choana and reached the nasopharynx. We all know in the lateral wall of the nasopharynx, we have the eustachian tube opening, right? Now, if the eustachian tube is a structure which is connecting your lateral wall of the nasopharynx with a middle ear, right? So if your eustachian tube has gotten blocked, that means it is the physiological functions of the eustachian tube cannot occur. So one of the important functions of eustachian tube is the drainage of middle ear secretions. So if the middle ear is not getting ventilated well and it's not draining well, it can lead to the development of serous otitis media. So sometimes you'll even see a case of CA maxilla has come to you with serous otitis media. So how do you connect them? This is how you connect it. This will basically indicate a nasopharyngeal extension of the mass. Then a history of radiation exposure. This will be a risk factor for malignancy. So there's multiple causes that we have to look forward to. We'll discuss the causes also later as we keep discussing our session today. So these are all the histories that you will be taking, and they'll all help you rule out something. They'll all help you have an indication just from the history itself, even before you have clinically examined your patient, that, hey, is this how much of the how much has the tumor spread? How advanced is this tumor? How will this affect your treatment protocol for the patient? So these are all very important history. So that completes our history taking and related questions over here. Now we are going to move on to discussing the clinical examination. Starting with our clinical examination, so we are just going to quickly skip through general and systemic examination. We didn't find anything significant here. We'll move on to the examination of the nose. So there is facial asymmetry present, left nasolabial fold obliterated, skin is normal, external osteocartilaginous framework normal, all of these other structures, bilateral ala, columella is normal. In left vestibule, we see some mucoid discharge present, and right vestibule is normal. On performing anterior rhinoscopy, we see that the septum is deviated to the right side. And when we look inside, on the left side, we see that there is a pale irregular mass filling the entire left nasal cavity with averted margins covered with mucoid discharge. And on probing, it is sensitive to touch, friable, bleeds on touch, firm in consistency, able to pass probe all around except for laterally. Then posterior rhinoscopy shows that there is a pale irregular mass seen in the left choana. The right choana is free. Eustachian tube opening is free on both sides, and posterior end of the septum is free. Paranasal sinuses, on checking them, we see that all of them are non-tender. And functional tests show that Cottel's test shows no improvement on both sides. Cole spatula test shows a decreased misting on the right side, absent misting on the left side. Cotton wool test shows a reduced movement on the right and absent movement on the left, and smell is present on both the sides. And before that, I forgot to mention this. Cranial nerve examination, there is a reduced sensation over the left cheek, and all other cranial nerves are intact. Moving on, now we are examining the cheek. On inspection, we see a diffuse swelling of the cheek, left cheek, approximately 2 into 3 cm in size, globular in shape, with ill-defined borders, and the skin of the swelling over the swelling looks normal. On palpation, the inspectory findings are confirmed. The swelling is extending vertically 1 cm from the lower eyelid to 3 cm above the lower border of the mandible, horizontally from 5 cm from the tragus, and continues medially onto the lateral wall of the nose, blunting the nasolabial fold. It has ill-defined borders, no local rise of temperature, no tenderness over swelling, hard in consistency, but the skin is free and pinchable, but swelling is fixed to the underlying bone and does not move independently of the maxillary movement. On examination of the eye, oral cavity, oropharynx, indirect laryngoscopy, ear examination and neck examination, it's normal. So this has been our clinical examination findings. So now we are going to discuss each one of these things. So first, starting with our anterior rhinoscopy findings. First, we found that the septum is deviated to the right side. So I told you, in the beginning, the first question that we discussed was like, in a case of CA maxilla, if there is bilateral nasal obstruction, what could be the possible causes? One of the causes was that the mass has grown so much that it is pushing the septum across the midline to the opposite side. So you can see that the septum has been deviated to the right side, and that is possibly why the patient is having a bilateral nasal obstruction. Next, we are looking at a pale and irregular mass. Now, pale and irregular mass. Irregular, this term irregular is a classic feature that will help you in distinguishing between a malignant mass versus a benign mass. A benign mass, for example, nasal polyp. How do you define it? We'll define it as like a pale, glistening, smooth mass. We'll never find it to be an irregular mass. So it will have a very smooth surface. Whereas in a malignancy, because of all the disordered tissue growth happening, you'll see an irregular surface. Then we are seeing that it has filled up the entire left nasal cavity and it has everted margins. Now, everted margins is another point that will help you in distinguishing malignancy from benign cases. So, in a malignancy, we'll definitely be seeing everted margins. Then we are seeing that it is covered with mucoid discharge. Maybe it is indicating there are some secondary obstructive changes which is causing this. For example, the sinus outflow tract probably is getting obstructed by the tumor, so that is leading to the development of a secondary sinusitis, which is leading to development of mucoid discharge. That could be the possible explanation over here. Next, now you are doing probing. The first thing that you have done is they found that this is sensitive to touch. Now, how can you explain that? So, when a malignant lesion grows, what it does is it can invade or involve the underlying mucosa and its sensory nerve supply. So, it will end up producing pain when it is touched. Whereas, if you compare to a case of polyp, for example, you will see that the polyp is insensitive to touch. So, polyp is basically an edematous hypertrophic mucosa. In that case, you will be seeing that polyp does not have any sensory, or it has very few sensory nerve endings. Whereas in case of a malignant lesion, it will involve the sensory nerve supply and hence it will be sensitive to touch. Next point, we are seeing that it is friable and bleeds on touch. Again, something that is suggesting malignancy, because this fragility and because it's so friable and bleeding on touch, it is probably pointing towards the abnormal neovascularization of the tumor tissue. So, in a case of a malignant tumor, the tumor vessels are structurally very abnormal. They are more thin-walled and they lack the normal supportive stroma. So because of this abnormal structure of the tumor vessels, they can end up rupturing easily with very minimal trauma. So that is how we explain friable and bleeds on touch. Then we saw that it is firm in consistency. Firm in consistency reflects the solid cellular nature of the malignant tissue. Versus if you were probing a polyp, you will see that this feels very soft in consistency because it is this hypertrophic edematous mucosa sort of. So that will have this very softish, boggy feeling. Versus a malignant mass, you will feel it to be more firm because of the solid cellular nature. Then you're seeing that you're able to pass the probe all around except for laterally. This is again a very key finding because this helps you in assessing what is the point of origin or attachment of the mass. The very fact that you're able to pass the probe everywhere except laterally is suggesting that probably the mass is arising somewhere from the lateral aspect of the nose, right? So it is coming from the lateral wall of the nose. And we know that the maxillary sinus opens into the middle meatus via its ostium in the lateral wall of the nose. So that is what it is indicating towards. So these are our anterior rhinoscopic findings that have been explained. Now, can you tell me some conditions where on probing the mass starts bleeding on touch? So it's not just malignancy, it could have multiple other differential diagnoses as well. So there can be inverted papilloma, sinonasal malignancy, rhinosporidiosis, typically a very vascular mass, and the bleeding here that you'll see is occurring because of the granulation tissue. Then we have GNA, a very vascular mass, hemangioma like capillary hemangioma, cavernous hemangioma, and hemangiopericytoma. These are all conditions where you'll see that it bleeds on touch when you probe. Next, moving on to discussing our posterior rhinoscopic findings. So in our posterior rhinoscopic findings, we saw that this is a pale irregular mass in the left choana. Right choana is free, both eustachian tube opening is free, and posterior end of on the end of the septum is also free. So this is confirming that basically the mass has grown posteriorly and it has extended to the level of the choana. So it's basically spanning the entire length of the anteroposterior length of the nasal cavity. And because we are seeing the right choana is free, this is confirmed that the disease is still confined unilaterally at the level of choana. So there has not been any septal crossing or bilateral spread through the posterior aspect. Then we also see that the eustachian tube opening is free. This is indicating that there is no nasopharyngeal extension. And posterior end of the septum being free is also suggesting that there is no posterior septal invasion occurring as well. So these are all points that you have derived about the extent of the tumor by doing your posterior rhinoscopy. And over here we can see Cottel's test. Again, these are functional tests. These will be more important for other causes of nasal obstruction. Usually Cottel's test, if it is positive, it usually denotes that there is some pathology in the valve area. Then Cole spatula test is showing a decreased misting and absent misting on the left side, meaning there's probably complete obstruction on the left side. Same for Cotton-Wool test. And we are seeing that the smell is present on both sides. Now we are going to move on to discussing why did we examine all of these other things that we are seeing as well. So here we have eye examination. Now why did we examine the eye? What is the importance of looking at the eye? So one of the very important things, features when there is orbital extension of the tumor that you will be seeing is proptosis. And looking previously when we were talking about history, I mentioned about how the direction of the proptosis will help you in deciding which sinus is the primary sinus involved over here. So two very important cases, CA maxilla versus CA ethmoid. So what will be the direction of proptosis? What kind of proptosis will you see in each of these cases? In case of CA maxilla, so if you remember the anatomy, the floor of the orbit is what forms the roof of the maxilla. So when the maxillary roof is basically the orbital floor. So when there is a superior extension of the tumor and it's eroding the orbital floor and going upwards, the direction you can already determine from here that the direction that the proptosis will happen is upwards and outwards because it is pushing the eye up. So upwards and outwards proptosis is what you'll see in a case of CA maxilla. Whereas in case of CA ethmoid, now let's imagine the CA ethmoid. So this is the nose. We have our ethmoids over here and then we have our orbit over here. So you can see how the lateral ethmoidal wall, the lamina papyracea over here, it is forming the lateral wall of the nose and the medial wall of the orbit. That is the relation with the orbit. So when there is a tumor involving the ethmoid sinuses, the tumor will erode the lamina papyracea and go towards the orbit. In this case, the eyeball will get displaced forwards, downwards and outwards. So you can see how this is how these two directions are very different, and that will itself indicate which is the primary sinus that the malignancy is arising from. And for this, you don't even need to do any kind of test. Just by noticing the patient, you can come to a conclusion which sinus is probably involved. So this is about eye examination. And then there's other stuff also that you look for. You check for diplopia, you check whether an extraocular muscle got involved, all of those other things. Then coming to oral cavity and oropharynx examination. Why did we do that? So if there is a extension of the tumor from the nasopharynx down to the soft palate in the oropharynx region, it will cause a restriction of movements of the soft palate. It can also lower the soft palate because of the mass, and you may even find a mass hanging in the oral cavity. All of these things are things that you can notice when you look at the oropharynx as well. So it is important that you check the oral cavity and oropharynx as well in your patient. Then we have ideal examination, indirect laryngoscopy. Why are we doing that? We are doing that to rule out presence of any kind of synchronous lesion in the larynx. So that's the importance over here. Next, we are examining the ear as well. This is something I already discussed. If the mass has reached the nasopharynx, it can block the eustachian tube opening, which lies in the lateral wall of the nasopharynx. And if the eustachian tube opening gets blocked, it cannot perform its function, and that will lead to the development of serous otitis media. So basically, by examining the ear, you can determine whether the tumor has extended posteriorly into the nasopharynx. Then coming to neck examination, we spoke about how even in a case of CA maxilla, you can have nodal involvement. And if you see a cervical lymph node involvement in sinonasal malignancy, that will end up upstaging your tumor. So that has been the importance of checking all these other areas other than just the primary area, which is your nose and sinuses. So that completes our clinical examination. Now we are going to talk, first we are going to summarize our case, and then we are going to discuss about a provisional diagnosis. So first let's summarize our case. So we have a 55-year-old male here who has come with the chief complaint of bilateral nasal obstruction for 2 months, nasal discharge for left side for 1.5 months, swelling in the cheek for 1 month. He had a history of smoking, bidi. Then this nasal obstruction, we saw that initially it involved only the left side, then rapidly it progressed to involve the right side in 20 days. An obstruction is complete on the left side and partial on the right side, continues throughout the day and with no aggravating or relieving factors. The left-sided nasal discharge is insidious in onset, mucoid in type, occasionally blood-stained, which is spontaneous. It is non-foul smelling, continuous in nature, and there is no aggravating or relieving factors. And swelling in left cheek, we saw that it's gradually progressive to attain the current size. It's associated with numbness of cheek, mouth breathing, snoring, hyponasal speech. And then when we examined, these are our anterior rhinoscopy findings, where we found a pale irregular mass in the left nasal cavity with everted margins covered with mucoid discharge, sensitive to touch, friable and bleeds on touch, firm in consistency, able to pass probe all around except for laterally. When you do posterior rhinoscopy, reveal the same pale irregular mass but only in the left guana, and the rest of the things were all free. Then when we looked at the cheek swelling, it was extending for a particular region over here that we mentioned. It had ill-defined borders, no local rise of temperature, no tenderness over swelling, hard in consistency, skin is free and pinchable. Skin is fixed to the underlying bone. So if skin is free and pinchable means that this is telling you that the skin has not been involved. So that is a very important factor over here that will help you in staging your tumor. But we are seeing that the swelling is fixed to the underlying bone. So that has been our whole case so far. We have summarized this. Now it's time to come to our provisional diagnosis. And when we come to a provisional diagnosis, what are we saying here? So this is possibly a left-sided malignant growth of the maxilla, and clinical staging is T3N0MX, probably stage 3. So this is our provisional diagnosis for our case. Now, the moment that you have given your provisional diagnosis, the next question that you are asked is, can you tell me what are the points that are in favor of your diagnosis? So let's start right from the history, then we'll talk about the clinical examination. So we saw that we had an elderly male. So this age group and the gender. Who is a smoker? So this is our addiction history. Then we also found that the patient is carpenter by occupation. So there is a history of exposure to wood dust. Next, we saw a very short duration of symptoms with a very rapid progression, which is definitely pointing towards malignancy. The symptoms are unrelating. There is no waxing and waning occurring here. We have symptoms of bilateral nasal obstruction, left-sided, blood-stained nasal discharge, and left cheek swelling and cheek numbness. So all of these things, cheek numbness, when we examine the patient, we see that there is a loss of sensation of the left cheek, indicating that there is a maxillary division of trigeminal nerve involvement. Then we saw an irregular mass. We discussed all of these points. Irregular mass, which is filling up the left nasal cavity, sensitive to touch, friable, bleeds on touch, firm in consistency, and able to pass all probe all around except laterally, probably indicating that maxillary sinus is probably the sinus of origin. And we found a diffuse swelling of the left cheek, which is with ill-defined borders, hard in consistency, skin not involved. Swelling is fixed to underlying bone. So diffuse swelling of the cheek is saying if the swelling has arisen from the maxillary sinus over here, there is infiltration of the subcutaneous tissue over here. But because the skin is free, we know that the subcutaneous tissue is involved, but the skin of the cheek is not involved. This will indicate that this is probably clinically a T3 stage, but not a T4 stage because skin involvement is not being seen over here. And we have V2 nerve involvement over here. We'll discuss the staging portion also in a little bit as I tell you more about the TNM staging. How did we come to our clinical staging as well? So all of these points, right from the point you started taking the age of the patient till the clinical examination of the patient, all of these things are pointing towards a malignant growth, and which is arising from the left side of the maxilla. And clinically, we feel that this is a stage T3N0 MX stage 3. Now, next let's look at the staging systems to understand why did we stage it that way. So now, for CA maxilla, we do not have just one staging system, we have multiple staging systems. So let's know that as well, because this is also a very common question asked. These are more important from the historical perspective. So we have Ohngren's classification, Lederman's classification, and TNM classification and staging. TNM is what we definitely need to know, but Ohngren's and Lederman's is also important from knowing from the viva perspective. So before we know the Ohngren's classification, the first landmark that we need to know is what is Ohngren's line. Now let's look at the image over here. Ohngren's line is actually a line which is running from the medial canthus of the eye to the angle of the mandible. This line is known as Ohngren's line. And what is the importance of this line? This gives us the Ohngren's classification, where Ohngren used this line to separate tumor into two groups. So this is a line here. He said that all the tumors that is lying posterior superior to this line, all the tumors that are arising from here are the suprastructural tumors. And he said that these tumors tend to be way more aggressive and poorly differentiated. Whereas all the tumors that is lying antero-inferior to this line, they are more amenable to treatment and they have a better prognosis as well. So basically this helps you in understanding the prognosis of the patient and how well the patient responds to the treatment. That was our Ohngren's classification. Next we have our Lederman's classification. But before that, let's try to see what is horizontal lines of Sebileau, because this will be very important in the Lederman's classification. So if we look at the lines over here, we have two horizontal lines passing over here. One line is passing through the floor of the orbit. This is our orbit and its floor. And one line is passing through the floor of the antrum. So these two lines are the lines which are known as horizontal lines of Sebileau. Now coming to Lederman's classification, what is this? So we have two horizontal lines of Sebileau, and then we have two vertical lines which is passing along the medial orbital wall. And this divides the whole area into suprastructure, mesostructure and infrastructure. Suprastructure is the area which contains the ethmoid sinus, the sphenoid sinus, frontal sinus and the olfactory area of the nose. Whereas the mesostructure contains the maxillary sinus and the respiratory area of the nose, and the infrastructure contains the alveolar process. This is our Lederman's classification over here. Now we came across the term suprastructure and infrastructure in both Lederman's classification as well as Ohngren's classification. So the next question could be, is the suprastructure and infrastructure mentioned over here the same in both the classification? Now that's a common question that a student usually gets confused in. No, it's actually not. The suprastructural area, as you can see in case of Ohngren's classification, is very different. The line is passing diagonally over here. And the suprastructure here does not coincide with the suprastructure that is mentioned in the Lederman's classification. So these are very different areas that we are looking at. So that's about these two important classifications. Next, we come to the classification that's more important for the clinical perspective, that is T&M classification. Now, T&M classification is very important that you remember it. First, we'll start with T staging. So, T staging, we have TX, where you cannot assess the tumor. Then we have TIS, which is indicating a carcinoma in situ. Next, we come to T1. Now, in this image, you can see that this is the tumor, right? So, you can see how it is limited to the antral mucosa only. And there is no erosion of the bone happening. So that is what T1 looks like, where the tumor is limited to the antral mucosa and there is no bony erosion. Next, coming to T2. Now in T2, you start to see some bony erosion or destruction happening. This can involve extension into the hard palate. It can also involve extension into the middle meatus. But the one area that it cannot involve is the posterior wall of the maxillary sinus and the pterygoid plate. Because if these gets involved, it will no longer be T2, it will be upstage. So in T2, what we see is, in the image itself, that you can see that the middle meatus has been involved. So this is a T2 tumor. So in T2, we see a tumor which is causing bony erosion or destruction, which includes extension into the hard palate or middle meatus, except for extension into the posterior wall of the maxillary sinus and the pterygoid plate. So that is our T2. Next, coming to T3. So here we are seeing there is involvement of 5 different things that will classify a tumor. Each one of those things can classify it as T3. So first let's look at that. Number 1, it has involved the posterior wall of the maxillary sinus. Number 2, subcutaneous tissue is involved. Number 3, either the floor or the medial wall of the orbit is involved. Number 4 is involvement of the pterygoid fossa. And number 5, ethmoid involvement. So if any of these 5 structures are involved, the tumor immediately becomes T3. So you can see in the first image here that the subcutaneous tissue is involved. In this part, we can see that the posterior wall of the maxillary sinus is involved. Over here that we can see that the ethmoid sinuses are involved. And here we can see that the floor of the orbit is starting to get involved. Even the medial wall is getting involved over here. So that will classify as T3. In our case, we have said that our tumor is probably clinically looking to be T3 because we have seen that there is a subcutaneous tissue involvement because we found a cheek swelling. But here we saw that the skin was normal. So the skin over the swelling was normal, but there is a subcutaneous tissue involvement and hence we placed it under T3. So that is a T3. Next, moving on, we have T4A. Now, T4A is commonly known as moderately advanced local disease, whereas T4B is known as very advanced local disease. So first, let's look at T4A. There are 6 structures that we will look at. T4A is, number 1, if there is involvement of anterior orbital content. Number 2 is skin of cheek, which I just mentioned. If the skin of the cheek was involved in our patient, the patient would have been T4 already. Third, we have pterygoid plates. Fourth, we have infratemporal fossa. Fifth is cribriform plate. And sixth, we have the sphenoid or the frontal sinus. So if any of these structures, 6 structures are involved, it will classify as T4A. So we can see over here how the sinuses are getting involved here. Here we are seeing that the skin of the cheek has been involved. So this would be our T4A tumor. Whereas if we look at T4B, which is very advanced local disease, we'll look at 7 structure involvement, starting with number 1, orbital apex. Number 2, if there is any dura involvement. Number 3, brain involvement. Number 4, middle cranial fossa involvement. Number 5, cranial nerve involvement except for the maxillary division of the trigeminal nerve. Number 6, nasopharynx. and number 7 is clivus. So if any of these 7 structures are involved, in that case our tumor will become T4B stage. In this particular image, we can see that the nasopharynx has gotten involved. And now the reason why we saw that we did have a cranial nerve involvement in our case, we had the maxillary division involved. But in this T4B, we can see that it mentions specifically cranial nerve involvement other than maxillary division of trigeminal nerve. That is the reason why our tumor is not T4B, it's only T3. So I hope you have understood so far why the T staging we have classified it as T3. Next, moving on, we have our N staging. Now, N staging in our particular case, we did not get any nodal involvement, but we still need to know about the N staging. NX is when you cannot assess, N0 is when there is no lymph node metastasis. Now, it's very important, just look at the highlighted portions over here. So from N1 to N3A, you will see that there is no extranodal extension. If in a patient you see that there is any kind of clinical extranodal extension, doesn't matter if there is single lymph node or multiple lymph node, ipsilateral or contralateral or bilateral, or what is the size, it will immediately fall under N3B. Now starting from N1, N1 is when you see single ipsilateral lymph node, which is 3 cm or less in greatest dimension without any extranodal extension. N2A, single and ipsilateral remains the same, but the size over here changes. So we have a size which is more than 3 cm, but not more than 6 cm. So the size has changed. N2B is, now the single is no longer single, this has become multiple, but it's still ipsilateral. Size remains the same where it is less than 6 cm. N2C is when this becomes bilateral or contralateral, size remains the same. So you can see how single parameter is changing as the stage progresses. N3A is anything, here the size will change. So anything which is more than 6 cm will immediately come under N3A. And if you find any kind of clinical extranodal extension, doesn't matter whether it is single or multiple, it falls under N3B. So that is our N staging of the tumor. M staging is very simple. M0 is no distant metastasis. M1 is distant metastasis. So this will bring us to the staging matrix now. And our staging matrix is, again, look at the highlighted portions to understand better. Stage 0 is when the carcinoma is in situ and there is N0 and M0. Stage 4C is very easy again. Any kind of metastasis present, it becomes stage 4C. It doesn't matter what is the T or what is the N staging. Then let's look at stage 1 and stage 2. This is also very important. In stage 1 and 2, you'll see that there is no nodal or metastatic involvement. It's just based on T staging. If it is T1, it becomes stage 1. T2, it becomes stage 2. Now, the difficulty is in understanding stage 3, stage 4A and stage 4B. So in stage 3, you'll see if it's a T1, T2 tumor, just N1 involvement brings it to stage 3. And if the tumor becomes T3, then directly we bypass all of these stages and end up at stage 3. So our particular case, we saw that stage T3, N0, M0. So our particular patient has fallen under this category. Stage 4A is when there is an N2 involvement happening or there is a T4A involvement happening. And stage 4B is when there is a N3 involvement happening and a T4B involvement happening. If you can remember these highlighted portions I've mentioned over here, this will help you in remembering the rest of the table because otherwise it's quite complex to remember. Very important, easily, if there is any metastasis, you directly go to the last stage. If there is no nodal and distant metastasis, stage 1 and 2 based on T1, T2. But the moment you become T3 or N1, it directly goes to stage 3. If T4A and N2, we directly go to stage 4A, and N3 and T4B, we directly go to stage 4B. And our particular case is falling under stage 3. So that's about the staging system of carcinoma of maxilla. This is a lot to remember, but I hope I've been able to explain it very easily to you. Next, I want to discuss with you a very important question that often comes across. If you get a case of nasal mass, you're often asked what is the differential diagnosis of a unilateral nasal mass case, and this will be a very common case scenario you'll face in your long cases. You are presented with a case of one-sided nasal mass. Now, how do you come to the conclusion, or how do you come to a provisional diagnosis, which one is the most likely one, and what will be your differential diagnosis? So the usual, like, this can be even a bigger list, but I'll just try to keep it very concise to the more important common conditions. So it can be a hypertrophied inferior turbinate, antrochoanal polyp, rhinosporidiosis, inverted papilloma, GNA, sinonasal malignancy, allergic fungal rhinosinusitis, meningoencephalocele, rhinolith, foreign body. Now let's look at each one of them. How will it look like, and what is the description, and how will you be able to differentiate between each one of them? So first, let's look at this image over here. This here is a hypertrophied inferior turbinate. If you had to describe this mass, you can see that it looks soft, pinkish mass, seen arising from the inferior part of the lateral wall of the nose. So the location is important. And when you try to probe it, you'll see that it is firm in consistency, not mobile, sensitive to touch because there's a lot of sensory nerve endings. And very importantly, it shrinks with vasoconstriction. So this will be a deciding factor that tells you that this is a hypertrophied inferior turbinate. Next, we have antrochoanal polyp. In antrochoanal polyp, you'll commonly see that if you look at the image, if you try to describe it, it looks like a single unilateral pale glistening polypoidal mass which has a very smooth surface. So I've been telling you earlier that how a benign polyp looks like. It has a very smooth glistening surface and it is mobile, soft in consistency, does not bleed on touch, insensitive to touch, and it does not shrink with vasoconstriction. And this particular point differentiates as well from a hypertrophied case of inferior turbinate. So our soft nature, as I mentioned, because it is a very edematous hypertrophic mass of tissue, therefore it is soft in consistency, does not have blood supply, it's not a very vascular thing, so it does not bleed on touch, it is insensitive to touch. Next, rhinosporidiosis. Typically, you will get a history of pond water bath. Sometimes you'll get history of farming occupation. And if you look at the mass, this looks like a pinkish red nasal mass with sheath-like extension, and usually you'll see this white dotted granular surface which is studded with white dots on the undersurface, and the white dots are representing the presence of sporangia. So if you look at this image, it kind of looks like a strawberry, right? So it has a very strawberry-like appearance. Usually this arises from sharp projections like spur. It is friable and readily bleeds on touch, and the reason is very important. You should know that because bleeding is happening because of granulation tissue, and it is also sensitive to touch. So these are the features that you'll see in a case of rhinosporidiosis. Next, very important, very most common benign nasal tumor is our inverted papilloma, and typically we'll see it in the middle-aged males. Typically, we'll see in 5th to 6th decade of life. And if you look at this image, this looks like a grayish, fleshy mass which is friable. This will bleed on touch. It is insensitive to touch, and it has a granular mulberry-like appearance, typically arising from lateral wall of the nose from the middle meatus, and it does not shrink with decongestants. These are the typical features that you need to remember clinically to be able to differentiate. Next, we have JNA. Now you can see how this mass looks very different from the other masses that we have seen so far. Now from the history perspective, usually it's a case of adolescent male, and they'll give a history of unprovoked episodes of profuse bleeding from the nose. And if you look at this mass, this looks like a globular pinkish or reddish mass, and usually we'll see it arising from the posterior part of the nasal cavity. And you can see that these vessels that you can see some dilated vessels on the surface. This is an extremely vascular mass. So in these cases, if we are seeing such a mass and we are suspecting from the history and from just looking at the mass, this could be a case of GNA. Probing is contraindicated here because it will lead to a lot of bleeding. So this is what GNA will look like. Next, we have sinonasal malignancy, which is our particular case today. Usually, you'll get an older age history, males more than females. There will be an addiction history or exposure, some kind of occupational exposure like nickel, chromium, furniture, rapidly progressive. And if we look at this image, we'll see an irregular pinkish or grayish mass with everted margins. It'll be friable, bleeds on touch, sensitive to touch, firm in consistency, and can even be ulcerated. This is what a typical sinonasal malignancy mass will look like. Next, this is what allergic fungal rhinosinusitis looks like. So usually you'll have a young patient. There'll be a case of unilateral or bilateral nasal polyposis, and you can see this thick, sticky, yellowish or greenish like mucus. This mucus is typically known as allergic mucin. It has a peanut butter-like consistency. So this is what an allergic fungal rhinosinusitis case will look like. Then we have meningoencephalocele. In meningoencephalocele, you can see that this is a smooth, rounded, pinkish grey, glistening mass. It is soft to cystic in consistency, sensitive to touch, and you'll see a positive Furstenberg test, meaning that the mass will expand with crying or straining in infants. And it can often be even pulsatile or reducible, and it can expand with Valsalva. So this is what meningoencephalocele will look like. Then we have rhinolith. Rhinolith, as you can see here, this will be a grayish brown or a greenish black mass. It has very irregular surface. When you touch it, you'll get a very stony hard feel, typically seen between the septum and the turbinates. And it is brittle. So when you try to manipulate it, it will easily break on manipulation. That's what rhinolith will look like. Another case is a foreign body of nose. This is more commonly you'll see in children, and they'll give a history of unilateral foul-smelling discharge. It can often be blood-stained and purulent as well. So that's been our differential diagnosis of a unilateral nasal mass, just the common conditions. Of course, there can be even more such diagnosis, but these are the common things you can look out for. I hope you've understood it, especially given the images and what you're looking out for. Now, next question, just in relation to this, before we move on to discussing carcinoma again, what is the rate of malignant transformation that we see in inverted papilloma? This is very important because in about 5 to 15% cases, a benign mass which is inverted papilloma can undergo a malignant transformation. And the most common malignant transformation that we see, the common histology that we see, is a case of squamous cell carcinoma. So any case of benign mass, if you are suspecting that there could be a chance of malignancy over here, that's something that you should rule out before proceeding with your treatment plan. Next, now let's discuss some things related to carcinoma of maxilla. So we have come to the diagnosis that this is our case of carcinoma of maxilla. Why are we saying that this is our case? How is our history and clinical examinations supporting the diagnosis, and how have we come to the staging? Now let's discuss more about the disease in itself. So what are the causes over here? First thing that I'll tell you is the wood dust exposure, which we have been talking about. Now, hardwood dust predisposes to adenocarcinoma, and softwood dust exposure predisposes to squamous cell carcinoma. The reason is that the biologically active compounds that are present in the wood dust, they end up impairing mucociliary clearance, and this ends up predisposing to carcinogenesis in the patient. Other than this, there can be an exposure to nickel, chromium. Smoking actually acts like a synergistic factor along with all these other exposure to cause the development of maxillary carcinoma. And then exposure to other chemicals like polycyclic hydrocarbon, aflatoxin, mustard gas, thorotrast, and even exposure to radiation. These are some of the causes of carcinoma of maxilla. Next, moving on. What is thorotrast? I just mentioned over here the word thorotrast. Thorotrast is actually thorium dioxide, which we use in paints and watch dials. So the people who are handling these things, they can get exposed to this. And that is also one relevant history that you get from occupation. Next, moving on, let's discuss the tumor spread patterns of carcinoma of maxilla. Now, this is extremely important. I will be making a separate video on this. You can check it out to understand more, but here we are going to discuss it briefly. When we are talking about tumor spread patterns, we can divide it into local spread, regional spread, and distant spread. We'll get into local spread and regional spread in a little bit, but before that, let's look at distant spread. Distant spread we see that in cases of carcinoma maxilla, actually distant metastasis at the time of presentation is not very common. It only develops in about 20% patients who have adenocarcinoma and 10% patients who have squamous cell carcinoma. And can you tell me what are all the different sites of distant metastasis in CA maxilla? So we have 5 sites here: bone, brain, liver, lung, and skin. These are the 5 sites that we will be checking in our patient for distant metastasis. Next, let's get into discussing the local tumor spread. Now, local tumor spread, we have to imagine the anatomy over here. So the green structure that we are seeing here, this is our maxilla. Now, let's try to imagine what are the structures in each direction. Starting from medially. So medially, you can see this is a medial direction. So what is the structure here? We are seeing the lateral wall of the nose and we have the nasal cavity. So if this was spreading medially from the CA maxilla, this lateral wall of the nose and nasal cavity is going to be involved. And accordingly, we'll be seeing more nasal symptoms, which is what we have seen in our particular case, where it has come to you with nasal obstruction, nasal discharge, which is blood stain. So we can see that we have had medial spread of tumor in our particular case. This will also help you in understanding, depending on what is the spread pattern, which direction it has spread on, what symptoms you'll be seeing. So medial spread will directly lead to nasal symptoms. Then let's look at superior spread. Superiorly, we are seeing that we have the orbit. So superiorly, if it was to go, it will go via the inferior orbital fissure and involve the orbit over here. In that case, you'll end up seeing all kinds of ocular symptoms. Like for instance, proptosis, diplopia, decreased vision, ophthalmoplegia, etc., etc. All of the ocular symptoms will arise. Then inferiorly, what structures are we seeing inferiorly? We are seeing the hard palate and the alveolus. So we have hard palate and alveolus. So our symptoms are going to be related to this. So an inferior spread will lead to a hard palate swelling or ulceration in the hard palate. You can even see ill-fitting dentures or discharging alveolus or history of tooth extraction, etc. So we'll basically be seeing more oral symptoms involving the palate and the alveolus. Next, let's look at anterolateral spread. So if we look at the lateral and anterior direction both, you can see that the structure that is right over here is the cheek and the skin over the cheek. So in our particular case, we saw that there is an anterolateral spread happening where the subcutaneous tissue of the cheek has been involved. So we are getting a cheek swelling. And if we also found that the patient had a cheek numbness, meaning the infraorbital nerve, this infraorbital foramen that we are seeing over here, which transmits the infraorbital nerve, has been involved. So those are the features that you will be seeing here. Then if you look at the posterior spread, we have the infratemporal fossa and the pterygopalatine fossa. So in all of the structures, the contents of infratemporal fossa and the pterygopalatine fossa, those will get involved and you'll get a different level of symptoms over here. And from the pterygopalatine fossa, it is very easy to have an intracranial spread through the various foramen present over here. So infratemporal fossa, one of the key features that you'll be looking out for is trismus, because here lies the medial pterygoid and the lateral pterygoid muscle. And these muscles, if they get involved, it will lead to restriction in the mouth opening. So that has been our local tumor spread, each direction, what structures will get involved. And now this spread itself will help you in understanding what are the symptoms that you will be finding. Next, talking about regional spread. Regional spread is basically lymphatic spread to the regional nodes. This is only seen in about 25 to 35% cases at some point during the course of the disease. But at the time of presentation, we have seen that only 10% of people have nodal disease. So that is why we'll see how this particular number impacts the treatment protocol as well. We'll discuss about it in some time. Now, can you tell me which lymph nodes get involved in CA maxilla? Actually, the first echelon lymph nodes over here would be the retropharyngeal lymph node of Rouvier. And the most common nodes that we'll see get involved over here are the submandibular nodes and the jugulodigastric nodes. And eventually, the level 2 nodes also get involved, the upper deep cervical nodes. So these are the lymph node involvement that you will look out for in your patient as well, which is why in your history I mentioned that you have to take the history of swelling in the neck and also examine the neck in your patient, because that's quite important for us. So these are the sites of distant metastasis. Now coming on to presentation of the patient. Now this is a very favorite question of the examiner, where they'll ask you, what are the groups of symptoms that you will be seeing in your patient? So we have 5 major groups here and a few minor ones as well. 5 major ones are nasal symptoms, orbital symptoms, facial symptoms, oral symptoms, neurological symptoms. Other than this, we also have some other symptoms like otological symptoms, cervical symptoms, and metastatic symptoms. Now, based on the local tumor spread that I just told you about, it will depend which symptoms your patient will come to you with. So, under nasal symptoms, we usually have nasal obstruction, nasal mass, epistaxis, blood-stained nasal discharge, smell disturbances, nasal deformity. Orbital symptoms, we have ocular pain, fullness in eyelid, epiphora, diplopia, restriction of eye movements, proptosis, loss of vision. Facial symptoms are cheek swelling, cheek numbness, both of which we found in our case, and invasion of skin, which will lead to ulceration over the skin. Then coming to oral symptoms, an inferior spread will cause an oral symptoms. We have because we have hard palate and the alveolus over here. And so the symptoms would be expansion of alveolus, dental pain, loosening of tooth, ill-fitting dentures, trismus, swelling of hard palate, gingival ulceration, fullness in the gingivobuccal sulcus, oroantral fistula. Neurological symptoms like abscess formation, CSF leak, meningitis, multiple cranial nerve palsies depending on from where it has spread. So you can see an involvement of second, third, fourth, sixth nerve and all of the trigeminal divisions as well. Then we have otological symptoms. If we have a spread involving the eustachian tube, the patient can have blocked ears, referred otalgia. Cervical symptoms, when there is a regional spread to the lymph nodes, we'll see a swelling in upper neck. And metastatic symptoms, depending on what has been involved, if the lungs are involved, we'll see cough and hemoptysis. If this bone is involved, we can see back pain, etc. These are all very important questions. Now coming to cranial nerve palsy, this is very important over here. Can you tell me what is the most common and the earliest cranial nerve that gets involved in a case of CA maxilla? The answer is very simple because you have it in your case itself. That is the maxillary division of the trigeminal nerve. So if you remember the staging of the TNM staging that I spoke about, in stage 4B I mentioned any cranial nerve involvement brings the patient to stage 4B except for the V2 nerve, because this is the most common and the earliest cranial nerve to get involved. There's another important MCQ question here. Can you tell me what is the last cranial nerve that gets involved in such cases? That is actually your facial nerve and your vestibulocochlear nerve. So these are some questions relating to the presentation of a case of CA maxilla. Now we are going to our next stage. There's a very common question asked, what are the Robbin's phases of CA maxilla? We have 4 phases over here. Phase 1 is when the patient presents with sinusitis. Phase 2 is when there is a presence of bony erosion or periostitis and the patient complains of dull aching pain. Phase 3 is when there is neurological involvement and the patient has deep pain. And phase 4 when there is distant metastasis present. So these are the different Robbin's phases of carcinoma of maxilla. So we have discussed quite a bit about how the patient will present to you with, what are the features you're looking for, what are the causes you're looking for, what kind of spread it can have, what are the staging systems. Now we are going to talk about the management of the case. So in our particular case, how are you going to manage the case? So whenever you're asked this question by your examiner, always remember, management is not equal to just treatment. Management will always comprise of investigations and treatment. So we are first going to investigate our case, confirm our diagnosis, and only then we are going to proceed to treating our case. So in our particular case, what are the investigations that we'll do? So we'll have some routine blood investigations that we'll do. Then we'll perform a diagnostic nasal endoscopy. The purpose being, we want to assess the origin and the extent of the tumor. We are going to check the posterior spread of the tumor into the nasopharynx, and this will also help us in guiding the site for taking a biopsy. Next, I'll be doing a biopsy. A biopsy will help you in confirming your diagnosis. This is a gold standard, and also find out what is the pathological type of the disease, because certain different pathological types can have different treatment options available to them. So it is important to do the biopsy, and basically biopsy will also help you in planning your treatment as well. Now, it's important to remember that before you perform biopsy, the other thing that you need to do is get your imaging done. So next investigation here is a contrast enhanced CT scan of the paranasal sinuses and the orbits. It's very important that you do it before the biopsy, because once you do biopsy, there will be an inflammatory response, and that inflammation itself can actually interfere with the findings that you see in your CT scan. The CT scan will help you in determining the site and extension of the tumor, as well as if there is any erosion, expansion of the bony sinus walls, etc. There are 3 E's that you can remember over here: extension of the tumor, erosion, and expansion. And the role of contrast over here is that helps you in finding out the vascularity of the tumor and delineation of the heterogeneity. Next, we can also do an MRI of the PNS and the orbits. This will be helpful for checking perineural invasion and perivascular spread of the tumor. This will also, because MRI basically helps you in giving more soft tissue details. So if you are having doubt that there is an orbital invasion or any other intracranial invasion, etc., like the brain, the dura, or the pterygopalatine fossa, infratemporal fossa, or nasopharynx has been involved, doing an MRI will help you in finding out the extent of the tumor. And this will also help you in differentiating between tumor and the retained secretions in the sinuses and mucosal thickening. Lastly, we'll also be doing PET CT to rule out any distant metastasis. So these are all the investigations that we do. Now, earlier we would also say X-ray PNS as well, but that's not something we do nowadays, because we have CT scan, which is a much better way of imaging. But if we had to just historically know a little bit about this, because you may be asked viva questions related to this, what are the different X-rays that you would do if it was a case of CA maxilla? We have X-ray paranasal sinuses water views. We have the X-ray of lateral skull, and we have X-ray base of skull. Now, if we had taken X-ray paranasal sinus water view, what are the findings you will be getting if it was a case of sinonasal malignancy? We will be seeing opacification, expansion of the sinus, and we'll also see erosion of the sinus walls. These are the findings that we will be looking out for. Next question, very easy, important one. What is triple line of Baclesee, and where do we see it? This is actually seen in an X-ray of the base of skull. There are 3 lines over here that you'll be looking out for. An S-shaped line which represents the posterior wall of the maxillary sinus. If this line has been eroded, it will indicate that there has been an extension into the subtemporal fossa. A C-shaped line which represents the lateral wall of the orbit. Erosion of this indicates extension into the orbital cavity. And a lower curvilinear line which represents the lesser wing of the sphenoid, and erosion of this will indicate that there is an extension towards the skull base. This is our triple line of Baclesee. Next question. Which pathological type of sinonasal malignancy has a good prognosis despite it having pulmonary metastasis? And the answer over here is adenoid cystic carcinoma. If you are able to control the primary site well, these cases, despite having distant metastasis and being an advanced stage of the disease, they actually end up having a good prognosis. Now that's been about investigations and things related to it. Next, coming on to treatment. How are we going to treat our case? Now, first of all, you'll obviously have to investigate your case. You have to confirm the staging of your tumor. Right now, we are operating on the basis that clinically we are staging it to be T3, N0 and MX, which is coming out to be a stage 3 tumor. But first of all, you'll have to confirm what is the radiological staging as well and see what is the extent of the tumor. Sometimes it can change radiologically, and that will decide what is your final staging. But we'll move forward with the fact that this is a stage 3 T3 tumor with N0 and MX. And we have also found that on biopsy that this is a case of squamous cell carcinoma, which is the most common pathological type that we see. And the second most common pathology that we see is a case of adenocarcinoma. Now, based on this assumption, how are you going to treat the case? In our case, we'll perform a surgery of total maxillectomy with post-operative radiotherapy and reconstruction. Then comes the question of, are we going to preserve the orbit or not? So orbital preservation is very important. So if in our particular case, we did not see any kind of orbital symptoms like diplopia, decreased vision or proptosis, etc., that suggests that we can probably go for a orbit preserving total maxillectomy once imaging has confirmed that there is no orbital invasion happening. So we will try to preserve the orbit. Next, coming to neck management, that is also another consideration. Neck management, because we did not have any clinically node positive case, our case is a clinically N0. So in maxillary sinus carcinoma, elective neck dissection does not have much of a role because it has been seen if it's clinically or radiologically N0 neck, because there is such a low rate of cervical nodal metastasis, there is no benefit of doing an elective neck dissection. So our treatment protocol over here is to perform a left total maxillectomy with postoperative radiotherapy and reconstruction, because total maxillectomy will leave behind a defect in itself. So that is our treatment here. Now we'll talk a little bit regarding the surgery, and we'll also talk a little bit about the radiotherapy and reconstruction. First, coming to surgery. Now, what are all the surgical approaches that you know of towards CA maxilla? We can have an endoscopic endonasal approach, lateral rhinotomy approach, Weber-Ferguson approach, mid-facial degloving approach, craniofacial resection, and transoral transpalatal approach. Depending on your particular case, you decide which approach you want to take. Next question, lateral rhinotomy approach. Now, this is very important. What is the incision that you use over here? The incision that you use here is typically known as Moore's incision. And can you describe the Moore's incision? This is what it looks like. So the upper end of the incision, it starts just above the level of the medial canthus at midpoint between the medial canthus and the dorsum of the nose. This incision now runs downward along the nasofacial groove. Then it will curve around the ala of the nose, and then it will go into the nasal vestibule. So lateral rhinotomy, the incision that we use here is the Moore's incision, and typically we use this to perform a medial maxillectomy. And this is only done if the tumor is very limited. Next, in our particular case, we are doing a total maxillectomy. So the incision involved in total maxillectomy is the Weber-Ferguson incision. So now let's see what is the Weber-Ferguson incision. So this again, it starts similarly, just like it is quite similar to Moore's, but it's a little bit more extended. Here we are going to start the incision. It starts with a lip splitting incision, which is usually given along the philtrum, and then it goes up, curves around the ala of the nose. It ascends up the lateral wall of the nose, which is the nasofacial groove, and then it continues till just below the level of the medial canthus. This is a typical Weber-Ferguson incision. Now, Weber-Ferguson incision has a lot of different modifications that you can have. So let's see what are these usual modifications. First, we have the Diffenbach's extension. What happens here? If you are extending the upper end of the Weber-Ferguson incision horizontally, so if we give a horizontal infraorbital extension over here, which runs laterally from below the medial canthus, it runs laterally along the lower eyelid towards the lateral canthus. This incision will be known as a Diffenbach's extension of the Weber-Ferguson. This helps in exposing the orbital rim and the floor. So this is our first modification. Second, we have the Lynch's extension. What is Lynch's extension? Here, the incision's upper end, we are carrying it further superomedially along the medial orbital wall to the medial end of the eyebrow. This, what it does is, it giving you added exposure to the ethmoid sinus and the medial orbit. So this is known as Lynch extension. And the third modification we'll see today is the Bold's extension. Here, you can see that there is a question mark shaped extension which is occurring from the lateral canthus into the temporal region. The reason why we will use this is because this will allow you, we know that there is a temporalis muscle that lies over here. We can use the temporalis muscle flap by extending the incision over here, because then what will happen is, if you extend this incision, you do not need to give a separate incision for the flap. So you're basically using the same incision of the maxillectomy to reconstruct. So you do not need a separate incision for this. So that's about Bold's extension. Now we have discussed all the approaches and the incisions. Now let's come to what is maxillectomy, what are the types of maxillectomy, and then we'll discuss the steps of total maxillectomy. So maxillectomy is a surgical procedure which we are using to partially or completely remove the maxillary bone. Now what are the different types that you know? So we can have partial maxillectomy, subtotal maxillectomy, total maxillectomy, and extended maxillectomy. And partial maxillectomy in itself can be divided into medial maxillectomy, infrastructural maxillectomy, and suprastructural maxillectomy. Let's look at each one of the definitions first. So medial maxillectomy, this image over here is showing you medial maxillectomy. So medial maxillectomy is when you are removing the lateral nasal wall, including the ethmoids. Then we have infrastructure maxillectomy, also known as inferior partial maxillectomy, where we are removing the hard palate, alveolus, and the lower part of the maxilla below the level of the infraorbital nerve. But important point to know here is we leave the orbital floor intact. So that will be our infrastructural maxillectomy. We are removing only the hard palate, the alveolus, and we keep below the level of the infraorbital nerve, and we are going to leave the orbital floor intact. Then we have suprastructural maxillectomy, also known as superior partial maxillectomy, where we remove upper maxilla and include the orbital floor or the roof of the antrum. But here the structure that we are preserving is the palate. So that's very important. So these are the different types of partial maxillectomy. Next, subtotal maxillectomy. Here we are removing at least 2 walls of the maxilla, including the palate, but important here is that we are sparing the orbital floor. So that is our subtotal maxillectomy. Then we have total maxillectomy, where we perform an en bloc removal of the entire maxilla, which we are going to do in our particular case, including the orbital floor with preservation of the orbital contents. This is the portion that we will be removing in a case of total maxillectomy. Next, we have extended maxillectomy. Extended maxillectomy is when the tumor is extended beyond the maxilla to the adjacent structures. So it can be that you need to do an orbital exenteration, or maybe that infratemporal fossa is involved, ethmoids are involved, skull base is involved. So the structure that you need to remove is also going to change. It will be beyond just the maxilla. If this involves the skull base, the term that you use is craniofacial resection. So these are our different types of maxillectomy. that we have. Now, in our particular case, we are going to be performing a total maxillectomy. So, we are going to look at what are the different steps that we will follow over here. Okay, so coming to steps of total maxillectomy. First, we'll start with our incision, which is the Weber-Ferguson incision. And as I have mentioned, we'll start with the transverse limb, which will be very close to the orbital margin, lid margin, and then it'll curve forward over the nasal bone at the medial canthus. It'll continue along the nasofacial groove, around the ala of the nose, along the crest of the philtrum, onto the lip. This will further continue inwards. There will be a mucosal extension. So the mucosal incision will look like this. It will continue along the midline of the hard palate till the point that it reaches at the junction of hard palate and soft palate. At that point, it will turn laterally, pass behind the maxillary tuberosity, curve around the alveolus anteriorly, and will join back. So this is our complete incision. After we have given the incision, we are going to raise the flap in a submuscular plane. After that, a major step is going to be the osteotomies. Now, there are four key sites over here that we need to remember. Number one is a palatal osteotomy, which we are going to give through the floor of the nasal cavity. Number two is a pterygoid plate separation. If you look at the posterior part, here is the pterygoid plate. So we'll separate out the maxilla at this point from the pterygoid plate with the help of a curved osteotomy, and we'll free it from the muscles. Then medially, we'll have the ethmoid cells in the frontal process of maxilla. So we'll give a cut over here, and laterally we'll give a cut through the body of the zygoma. And once we have done all of this, we are going to free the maxilla. So all the attachments, we have given the cuts over here. We are going to free up the maxilla by dissecting the rest of the tissues, whatever is attached, and then we are going to remove the maxilla en bloc. We'll complete the resection. Then we will try to secure hemostasis. And if in your particular case, if you need to do an orbital exenteration, then we'll do the orbital exenteration. And if you don't, then we'll skip that step. And lastly, we will move on to the reconstruction stage. So these are all the steps of total maxillectomy in brief. I'll try to make a separate video on this where we talk about the steps much more in details. But for now, just a brief intro to the steps of total maxillectomy. Next, a very important question comes in. Can you tell me which vessel is commonly responsible for the bleeding that you see after you have taken out the maxilla in total maxillectomy? And the answer is typically we see pterygoid venous plexus bleed. And to deal with this, we usually put hot saline packs inside the area, and that helps in controlling the bleeding. There can also be an internal maxillary artery bleed. In that case, you would have to cauterize the area. Next question. After you have done total maxillectomy, you're left behind with the defect, right? So there's this one classification that you need to know, which is the Brown and Shaw classification of maxillary and mid-facial defects. This has two parts. One is the vertical classification and the second one is the horizontal classification. Vertical classification is dependent on the extent of bone loss that has happened. So we have 6 types, as you can see in the image over here. Type 1 is when the maxillectomy is not causing an oronasal fistula. This. Second, type 2 is when you are seeing maxillectomy which does not involve the orbit. So you can see here orbit is not involved. Type 3, here we are seeing that maxillectomy which involves the orbital adnexa, but we perform it with orbital retention. Type 4 is when we are doing maxillectomy with orbital enucleation or exenteration. Type 5 is when we have a orbitomaxillary defect, and type 6 is when we have a nasomaxillary defect. So that is our vertical classification of Brown and Shaw classification of maxillary and midfacial defects. So these are our defects. Then we have the horizontal classification. So horizontal classification here, basically the classes 2 to 4, we further qualify them based on the horizontal extension that has occurred across the palate and the dental arch. So you can see in this type A, we are seeing that there is only a palatal defect and it does not involve the dental alveolus. Type B is when we are seeing less than equal to half of a unilateral maxillectomy. So you can see this is involving only less than equal to half of an unilateral maxillectomy. C is when we are seeing less than equal to half of a bilateral or a transverse anterior maxillectomy. That's what we are seeing here. And type D is when there is a greater than half of maxillectomy resection. So this is our horizontal classification, which is based on how much of the palate and dental arch has been involved. And we classify according to both of these two types, and then each patient gets a combined code. For example, a defect can be classified as 2B, meaning maxillectomy which does not involve the orbit with less than equal to half of a unilateral maxillectomy. Now, based on these defects, we basically decide what kind of reconstruction we would do. This is just for more viva purposes. Class 1 to 2B, usually this is closed with either an obturator or a reconstruction. If you're using a flap, the fasciocutaneous radial forearm flap will give you good results. Class 3 defects usually suggest the loss of support for orbit, anterior cheek, dental arch, and usually requires a microvascular reconstruction. In these cases, a deep circumflex iliac artery bone flap, which is the DCIA flap, and the thoracodorsal angular artery TDAA flap, which is based on scapula with latissimus dorsi, teres major, and serratus anterior muscle. TCIA and TDAA are good flaps for this particular case. Class 4 defects is typically an advanced stage of the disease which has poor prognosis. Here, reconstruction should be secondary to the consideration of whether surgical resection is even feasible or recommended or not. In these cases also, in case you do need reconstruction, DCIA and TDAA flaps are good because the muscle will provide vascularity to support the dura and prevent any CSF leakage. Then we have class 5 defects. Here, after orbital exenteration, a temporoparietal or temporalis flap will facilitate the placement of an orbital prosthesis. And lastly, we have a class 6 defect which does well with an osteocutaneous radial forearm flap. So this is about the Brown and Shaw classification. Lastly, we have come to reconstruction options after total maxillectomy. So if you were asked what are your different reconstruction options that you have, we have 3 options. Prosthesis, which involves the usage of obturator. We'll talk about obturator after this. Then we have option of flaps, and third we have alloplastic or implant based. Now implant based can be like titanium mesh or plates used for orbital floor or osseointegrated implants for dental rehabilitation. We'll talk about obturator and flaps next. So looking at obturator, can you first tell me what is an obturator and what are the different types of obturator that you know? So an obturator is basically a prosthetic device which is used to close or seal a defect created after maxillectomy and allowing a separation of oral and nasal cavities. The advantages of using obturator is that it will prevent the fluid and food from going into the nose. It will immediately improve in speech and deglutition after operation. It has better cosmetic results, shorter operative time, and it is suitable for elderly or unfit patients where we cannot do a long flap surgery. Disadvantages of using obturator is that it is difficult in maintaining the oral hygiene and it may require repeated adjustments. That is the basis of obturator. Next, we are going to learn what are the different types of obturator. So based on the timing which you are introducing the obturator at, we have 3 types. Surgical or immediate obturator, interim or transitional obturator, definitive or permanent obturator. Now let's look at each one of them. Surgical or immediate obturator is the one that you're immediately placing at the time of surgery after you have completed your maxillectomy. This is usually we take preoperative impressions of the patient and we have prefabricated it. And typically, we use it only for about the first 7 to 10 days, which is corresponding to the period that the surgical packing has been left in the cavity to help with healing and hemostasis. Usually, the material used is polymethyl methacrylate acrylic resin. Now, what is the use of this immediate obturator that we are using? This will give you an immediate separation of the oral and nasal cavity, as a result of which it will allow early feeding and speech in your patient. This will also help with the supporting the packing that you have placed in, and it also definitely has a very important psychological benefit, because if the patient wakes up and sees that there's the defect that you leave behind after you perform total maxillectomy, it can psychologically affect the patient a lot. So using a surgical obturator, these are the purposes that we have. Moving on, we have interim or transitional obturator. Now, after the surgical obturator is removed around 7 to 10 days post-operatively, once you have removed the initial packing and the healing has early healing has happened, then is the time that you put in the interim or transitional obturator. Typically, we use this for about 3 to 6 months until the whole surgical cavity has fully healed, the granulation tissue has matured, and tissue contraction or shrinkage has stopped. During this period, you may even need to keep on modifying your obturator, because as the cavity keeps on healing, it can change the shape because the swelling will resolve, the healing will progress. So that is our transitional obturator. The main purpose of this obturator being, it's basically acting as a bridge until the tissue bed stabilizes. And typically, if your patient is receiving post-op radiotherapy, then the interim obturator should be continued throughout the whole course of the radiation, because it will help in maintaining the fit and shield the normal tissue from the radiation. And we should delay the use of definitive obturator in these cases until after the radiotherapy is completed, because radiotherapy itself will bring in some changes in the tissue architecture. So during the whole time of the radiotherapy, we will prefer to use an interim or transitional obturator. Next, we have the third kind, which is the definitive or the permanent obturator. Now, this obturator is fabricated typically around 3 to 6 months post-operatively, once we have determined that the cavity has completely healed and stabilized and no further contraction of the cavity is expected. And we'll, as I mentioned just now, we will delay it till the radiotherapy is completely done. Now, this is aesthetically more superior, usually made with more durable, well-fitted material, and we try to include a hollow bulb design so that the weight of the obturator is reduced and it improves the comfort of the patient. So the purpose of this being that it's providing you with optimal function, better retention, stability, speech, and mastication. So these are our different types of obturators, and this is very important viva question you'll be asked if you get a case of CA Maxilla. Last, let's come on to discussing some of the flaps. We'll just briefly go across it. What are the different flaps that you can use? So we can either use a local flap, or we can use a regional pedicled flap, or a microvascularized free flap. Now, what are these different types of flaps and some examples of it? Local flap is when you take the tissue right from next to the defect and you just reposition it, and it keeps staying attached to its own nearby blood supply. For example, using a buccal fat pad or palatal mucopericordial island flap. Second, we have regional pedicled flap. Here also you are taking tissue from a nearby body region and then you are moving it into the defect while it is still tethered to the intact blood vessel. So this is not from right next to the defect, but however it's in a region which is close by to the defect. Example of this is a buccinator flap, temporalis muscle flap, or a temporoparietal fascia flap, or a cervicopectoral flap. Then we have microvascularized free flap. What is that? This is when you have taken tissue from a distant part of the body, that is nowhere close to the area that you are performing your surgery on, and then we completely detach it and its blood vessels are surgically reconnected under a microscope at the site of the defect. That is a case of microvascular free flap. Examples are rectus abdomini flap, radial forearm flap, iliac crest flap, latissimus dorsi flap, and osteofasciocutaneous fibula flap. So these are the different flaps that you can use for reconstruction as well. Lastly, we'll talk a little bit about postoperative radiotherapy before ending the class. I know this has gotten a little long, but these are all the questions that you're usually asked if you do get a case of CA maxilla, so it is important to get through all of them. So what would be the indications of post-op radiotherapy? In our particular case, we have used post-op radiotherapy. So the indications are T3 or T4 primary tumors. Our case was a T3 tumor. Then if you have close or positive surgical margins, perineural invasion, lymphovascular invasion, bone invasion, multiple positive lymph nodes, and extracapsular nodal extension. In all of these cases, we will give post-op radiotherapy. Can you tell me what is the dose of radiotherapy and type of radiotherapy that you use? We will give an intensity modulated radiotherapy. Usually we start within 6 weeks of surgery. And the dosage is 60 to 65 gray delivered over 30 fractions. Last question for the day. How will you follow up your patient? So we'll follow up every 3 months for the first year, then every 6 months for the next 4 years, and then from there on onwards, we'll check every yearly. So that completes our discussion for today. I know it's become a very lengthy discussion, but I hope I've been able to cover most of the topics that are usually asked around if you do get a case of CA maxilla. If you have any doubts regarding this or any other questions, you can note them down in the comment section and I'll get back to you. Thank you.